Okay, everybody, let's get going. Let's keep this session going. We're a little behind time. Hopefully we can make some up. I've decided to drop Dr. Aksamit from the program. Yeah, boom. First, I want to thank Rachel. Is Rach here? Hey, Rach, that was as good a talk on environmental NTM acquisition as I've ever heard. Thank you so much. That was really, really excellent. I mean, the two things everybody wants to know, regardless, is how did I get this and how do I keep from getting it again? Unfortunately, you only answered half of that, Rachel, but that's okay. So the next session we have is patient phenotypes in NTM and bronchiectasis with my friend from the Mayo Clinic, Tim Aksamit, and my friend from the National Institutes of Health, Ken Olivier. Tim.
All right, good morning, and thank you, Dave, and the conference organizers for the chance to come and share some perspectives with you today. This is absolutely a fantastic conference, and I would again give a shout out to especially the patients that are here. You're really an inspirational group to us. The support groups are constantly really adding a great deal, not only of support, but helping to move us forward on where we need to go to have a better understanding of what it means to have NTM lung disease. I think one of the takeaways, if I was to leave you with a point, is the key and the answer to a lot of our success will be advance the science. And I think this is a great example, and I use that term loosely. It's not just about the biology, but also about your clinical experience of advancing the science if we're going to make progress. What I would share with you, a number of disclosures. I participate in a number of clinical trials, but all the monies and support as part of that go to my employer, the Mayo Clinic. I don't receive anything on a personal or research basis. Over the next 10 or 15 minutes, and I'm going to do just half of the NTM and bronchiectasis phenotype, I'm going to restrict my comments to bronchiectasis, and my colleague, Dr. Olivier from the NIH, will talk a little bit about NTM phenotype. But I'm going to share over this next 10 or 15 minutes just a little background information and my personal perspective. I just want to review a little bit of what we mean by phenotype and endotype, and then leave you with a couple of summary thoughts. So first, let's talk about background. And the background that I want to start with, and this is a slide I think most of you who have heard me talk before have seen this slide, and this is where we are as far as FDA-approved therapies, antibiotics for NCF, bronchiectasis, non-cystic fibrosis bronchiectasis, and from this point forward, I'll refer to as just bronchiectasis. So there are no FDA-approved inhaled antibiotics or therapies for bronchiectasis at this point, and that's our starting position. And we think when we talk about bronchiectasis, at least my perspective is, we think about permanently dilated bronchial tubes with impaired mucociliary clearance, retention of mucus or secretions, and it sets up what was described as a vicious cycle of recurrent infection, inflammation, and further airway damage, something that is a recurrent theme, and we're going to hear more about as this conference progresses. In the lower right-hand corner is the model of this vicious cycle. It goes around, and a lot of what we heard from our patients about airway clearance is designed to try to break that cycle. When I think about bronchiectasis, I think it's also important that we get the definitions right, that we understand that we're talking all about the same thing. And so when I think about bronchiectasis, as was mentioned, most often it's initially recognized by a chest radiograph, or more commonly chest CT scan. The bronchial tube is, as said, dilated, and that's relative to the blood vessel next to it. It has a tendency to not taper as it normally would, and may be seen in the periphery of the lungs, often associated with thickening, representing mucus and inflammation in the bronchial tube, and then the plugging of mucus that goes along with this. And I put this slide up just to remind us that this ratio in itself doesn't always add a specificity. That is, the ratio itself may be seen in an abnormal set of numbers, but it may not represent bronchiectasis. So we have to be careful when we're making diagnoses of bronchiectasis or we're enrolling in clinical trials that we're in fact looking at what we think is actual bronchiectasis. And we understand that for individuals with COPD, chronic obstructive pulmonary disease, most often felt to be smoking-related lung disease, or in elderly patients, we can have an increased bronchial arterial ratio without having frank bronchiectasis. And the other part of why we ended up with this blank slide as far as FDA-approved therapies is because of the heterogeneity. And we understand that the presentation that you've had, as we heard from our patients, is very heterogeneous. And that heterogeneity, from a science standpoint, also contributes to why we see such a variable response. It's not as simple as a single type of inflammatory response or a single finding that's consistent across all bronchiectasis, but there's a great deal of variation. This variation is coupled to what we understand are changes that occur in the airway as we go from normal to diseased lung, and that change that occurs will vary between different cohorts and likely contributed to some of the heterogeneity and what many of us think have contributed to why we've not been able to meet primary endpoints for clinical trials and cross the finish line. As a reflection of some of that heterogeneity, when we think about what some of the causes are of bronchiectasis, and this is taken from a review by Dr. Chalmers in the UK, looking at causes for bronchiectasis, by far worldwide, and these are taken from different areas around the world, in Europe, Africa, Asia, and Australia, but the most common etiology is either idiopathic, that is, we're not smart enough to figure it out yet, or post-infectious, which is often a diagnosis of exclusion, but then there are a number of other associated diseases, one of which was PCD, or primary ciliary dyskinesia, as we had heard, alpha-1 antitrypsin that we heard, and then in particular COPD, this smoking-related obstructive lung disease, and asthma. And what we've come to appreciate is that when we start thinking about airway diseases, and this is one of the recurrent themes, is it's not just about COPD and asthma anymore. And in fact, as we understand with this heterogeneity, there's a significant amount of overlap. And if we think about this in terms of Venn diagrams, I'm going to come back to, we're going to see significant overlap. And in fact, as we have the COPD group looking at also inflammation in the airways, that there is a significant overlap with bronchiectasis, and there have been now studies that for individuals with more advanced COPD or more advanced asthma, that sometimes in more than half of those groups, there is significant bronchiectasis. Now the question is, what's the significance of that from a clinical standpoint, and how do we respond to it? We understand that from the U.S. registry, this overlap is not uncommon. That is, 20% of the patients enrolled in the U.S. registry with a primary diagnosis of bronchiectasis were also given a diagnosis of COPD. Taken from a database assessment by Dr. Winthrop and his colleagues in Oregon, that over 50% of patients that were diagnosed with bronchiectasis also had a label, or at least a Medicare diagnosis label, of COPD. This has been eerily similar to what was just recently published in a German similar type of study where they had, I think it was 58% of patients with COPD and a primary diagnosis of bronchiectasis. So when we think about phenotypes and endotypes, what do we actually mean? And when we talk about a phenotype, we're talking about clinical characteristics. That is how someone feels, cough, sputum, what's happening with the exacerbation rates, how they're feeling, and that's in contrast to the endotype, which is more based in biology or the genetics of a situation. And we're going to look at some of those examples. And in fact, the group from Europe have looked at clinical phenotypes in bronchiectasis, and again, this is non-cystic fibrosis bronchiectasis. They took a number of clinical characteristics, including demographics, comorbidities, radiographic scores, microbiology, lab status, and so forth, and then made it with a cluster analysis, different groups of individuals. And so these are phenotypic clusters of patients, and they broke those up into those that had Pseudomonas isolated in sputum, those that had other pathogens but not Pseudomonas, those that had brought up daily sputum but didn't have any pathogens for the most part, or what we call dry bronchiectasis, where it was present on CT scan but not with associated sputum that they were producing. Interestingly, and just as we had heard about the NTM distribution and speaking to this heterogeneity across the centers that participated in the UK, Belgium, Italy, Ireland, and Greece, it's not a similar distribution, so it depends on where you are, and it also holds true within North America as well, that there are variations between these different clusters or groups of individuals of different phenotypes. And I just wanted to take from the same reference that COPD, this smoking-related associated lung, is one of the significant variations in between these different clusters. So we have to be really clear when we start thinking about individualized approaches to patient care. What are we really dealing with? And I need to be very clear that each one of those components is identified, and we can't assume that someone with a diagnosis of bronchiectasis is the same across the board. And in fact, what I would encourage you that as you share information and what works or doesn't work for you as far as airway clearance or other approaches, what works for you may or may not work for another patient with bronchiectasis, in part because it may be a different type of bronchiectasis or a different phenotype, a different cluster, and that not all individuals will fit the same bill. When we look at the biology of this is a review by Dr. Olivier, Dr. Flume, who will speak a little bit later, looking at endotypes and the genetics of this. And again, what they pointed out to us in Venn diagrams, it's not just about a single biology, not just about a single clinical characteristic, but an overlap of this. And what that overlap then translates into is the need for each one of us, as you come and approach this particular problem, is to try to identify what is it about that biology of a particular patient, what is it about those specific characteristics to best approach this for successful therapy. One of the topics that has come to become more popular, and this is a recent publication just earlier this year, talking about treatable traits. And that is to identify those characteristics and or biological issues, genetic included, to be able to deal with that specific aspect. And so this is taken as a report. There was a conference in Australia last year looking primarily at COPD, but trying to identify these different groups of phenotypes and endotypes so that we could then identify treatable traits for an individualized precision medicine approach, if you will, to each go after the respective abnormalities. This was highlighted by a review in the European Respiratory Journal by Dr. Chalmers and colleagues as well, and a case-based approach. And just by that title, case-based approach, we're already assigning something or a label to an individual with bronchiectasis. And just as an example taken from this paper, we have NTM as a part of one of the cases of NTM with bronchiectasis, as well as another separate example of cystic fibrosis, which is based in biology, not necessarily phenotype, but the endotype. And so we have now therapies, and again, the point here is that we want to individualize, if you will, very specific treatable traits to identify how best to approach the best therapy on an individualized precision medicine basis as you come into the clinic. As Dr. Griffith had said, this is up to date. This was just in this week's New England Journal of Medicine. It's a review of muco-obstructive lung diseases, including but not limited to COPD and non-CF bronchiectasis from Dr. Boucher in North Carolina. And again, I wanted to bring to your attention, and it's a busy slide, but to understand that we're starting to look at what is going on with the mucus itself, for example. It's not just a single pattern, and that we used to think, well, there's just mucus there and the cilia that clear it. Well, it's much more complicated. There are different mucins, MUC, MUC5 was probably the longest, and you can kind of review this. And if we look at the amount of mucus across healthy individuals, COPD, bronchiectasis, CF, and then PCD patients, we understand that the kind and amount of mucus will vary, and there's a lot of interaction that occurs with the mucus and in the biofilm. So it's not just a biofilm that's in your water pipes that Dr. Thompson had told us about, but we have biofilms within our airways, and that's the interface that we interact with our environment. So it's no wonder that the complexities of these different mucins and mucin products will have an impact on what happens with the type of inflammatory response, which then translates into these phenotypes of how much cough do you have, how much systemic symptoms do I have, how crummy do you feel, and what can we do to correct that? This is, again, taken from Dr. Boucher's, and I would just share with you that the model is changing. We're understanding more and more about the different mucins, the MUC5, MUC4, 1 through 6 mucins that have an impact relative to the cilia, the amount of hydration that's there. Many of you are on airway clearance regimens, and then specifically the mechanical parts, not only the high-frequency chest wall isolation, but some of you may be on nebulized hypertonic saline or other types of mucolytic agents to try to loosen up that sputum and understand that that does likely have an impact on the biofilms, i.e. on the mucus that goes on within the airways, and then sets up this inflammatory heterogeneity that's within the airway, translating into, are you feeling better or worse, and how many exacerbations are you having? And that at the bottom of this is just the caption of microinflammatory cycles, that is the vicious cycle of the muco-obstructive disease. And again, we're starting to become full circle and understand that there is a great deal of science behind this whole notion of vicious cycle, and it's not just about a single pathogen, single infection, but the mucus and the clearance and all of these factors, both from a biology and endotype, as well as the clinical characteristics from a phenotype, have an impact on then what happens and how well or poorly you feel. So in summary, what I would leave you with is that it's my opinion that the historical paradigm of bronchiectasis of a single organism or a single infection, Pseudomonas, is insufficient to really tell us about the unmet knowledge gap, that the relationships that we've come to understand of these different endotypes, the biology, if you will, and the resulting clinical phenotypes are very complex, and we're just beginning to understand a lot of those factors that are likely interrelated, overlap in a Venn diagram standpoint, and that the role of other common airway diseases, including but not limited to COPD, asthma, and the like, are really represent opportunities. We heard about the NTM issues, that inhaled corticosteroids increases the risk of NTM infection, but in those instances where there's underlying asthma or there's underlying COPD, inhaled corticosteroids may be necessary to treat that treatable trait. And so we have to incorporate that. Likewise, if it's not a treatable trait, we want to back off on that and try to individualize that medicine. And then by doing so, we want to advance that science and close the knowledge gap. And with that, I'm going to just stop there, and I'm going to ask my colleague, Dr. Olivier, to kind of carry us through then NTM. Thank you very much for your time.
Okay, thanks, Tim. We'll just take you through a similar type of presentation with regard to NTM. So I do have some relationships with commercial interests that the NIH has cooperative research and development agreements with. So why is it important to categorize patients with NTM? And Tim went through some of this. A big reason is because of what introducing heterogeneity into clinical trials can do in terms of potentially leading to treatment failure. If you're mixing patients with different types of disease together, an action on a particular drug may be different depending on those categorizations, and with them mixed together, you mask an effect that may be tailorable to a potential group of patients. Also, different phenotypes have different prognosis, and we'll go through some of that. This is just sort of a brief outline of ways that you might categorize NTM patients. It can be done by organism, by species. It can be done by radiographic presentation. and by associated conditions and comorbidities, such as the different causes of the underlying bronchiectasis. With regard to differences in organisms, there have been several studies similar to this done in cystic fibrosis patients, but this study was looking at the difference of effect on change in lung function over time, which is on the x-axis at the bottom, with the area to the left side being a decline in lung function over time, the right side being an increase in lung function over time. And it compared the effect of isolating mycobacteria to other organisms, particularly gram-negative organisms that patients with cystic fibrosis may have. And while this was specific to CF, I think the concept applies for non-CF bronchiectasis underlying the condition as well. And if you look at the top group there, Mycobacterium abscessus complex, had the greatest effect on decline in lung function over time of any of these organisms, especially organisms like Burkholderia cepacia, which traditionally has been associated with a very negative impact on the clinical course of cystic fibrosis lung disease. And if you compare the effect of M. abscessus to the effect of M. avium complex, there was a big difference. So for M. avium complex, that line down the middle, the vertical line, basically shows where it doesn't either have a positive or a negative effect in terms of effect on lung function over time, which is where MAC fell. They then looked at what happens if you treat the patients with M. abscessus and MAC. And if you look at the bottom, this is a comparison once they cleared those organisms. So this is with effective treatment for M. avium complex. Not much difference was seen relative to just having it. So it didn't make a big difference in lung function if it was acquired. When it went away, it didn't seem to make a positive effect. However, if you look at the effect of making M. abscessus go away, the positive effect of change in lung function was almost equivalent to the negative effect of having it. And the graph on the right side there shows in sort of linear form what the differences of acquisition and clearance of that organism means. And so on the left-hand side of that, that's the slope of decline in lung function before the first isolation of M. abscessus. The part in the middle is after isolation of M. abscessus, and then the part to the right-hand side is the effect of making it go away. And so you see a great increase in the slope of that decline in lung function over time when M. abscessus is first isolated, and then when it clears, there's a lessening of that slope of decline over time reflected in the organism going away. So big differences in the effect of having mycobacteria by species and big differences in the effect of making it go away by species. Another commonly reported way of categorizing patients with NTM is based on radiographic appearance. And this is a very nice study done by Dr. Ko in South Korea, where they categorized patients. These are patients with treatment-naive Mycobacterium avium complex into 3 different categories. And many of us are familiar with categorizing by sort of fibrocavitary versus nodular bronchiectasis, but this took it one step further. So if you look at what we call fibrocavitary disease, and there's a representative, what we call a coronal section of the CT scan shown at the top, this is characterized by having cavitary lesions, pleural thickening. It's predominantly in the upper lobes. And the characteristics of the patients, they tend to be older males and associated with things like previous pulmonary tuberculosis or COPD. The nodular bronchiectatic disease, unassociated with cavities, as you see on the right-hand side radiographically, this is characterized by having bilateral bronchiectasis with multiple nodules. And the arrows, the black arrows on that CT cross-sectional image are pointing to areas of sort of branching nodules, what the radiologists call tree-in-bud infiltrates. This is predominantly seen in postmenopausal non-smoking females, contrasting it to the top category. And then the third category they looked at was what they called cavitary nodular bronchiectatic disease, characterized by the cross-sectional CT at the bottom on the left. These patients had the traditional sort of bronchiectasis that you can see in sort of the top part of that CT scan, but in addition, there was a thick-walled cavity in the right lower lung field of this image. And they then took those categories and they looked at what the outcomes of those patients were with regard to treatment. So they defined a favorable outcome as achieving culture conversion and remaining with negative cultures over a 12-month period while on an ATS-IDSA guidelines-based regimen. And so of the subjects that participated or that were evaluated in this, 84% of them following these regimens had that definition of a favorable outcome. They then looked at the characteristics of patients that did not achieve a favorable outcome, an unfavorable outcome. And the things that came out significant are being a male, and so again, that's more associated with the fibrocavitary type disease, but that was an independent risk factor, which almost doubled the risk of having an unfavorable outcome compared to females. And that held up both in looking at it as a single variable and in a multivariable odds ratio or outcome that took into account a variety of other factors. And then if you look at that disease type and how that breaks down, those that had non-cavitary nodular bronchiectatic disease were sort of the reference group. If you had cavities associated with that nodular bronchiectasis, that again more than doubled your risk of having an unfavorable outcome. And then if you had fibrocavitary disease, as we discussed, that also more than doubled your risk of having an unfavorable outcome. And those held up both in the single variable and multivariable analyses. So this radiographic presentation and its sort of associated characteristics can make a big difference in terms of response to treatment. And I think in looking at clinical trials, it's important to keep that in mind and making sure that we're looking at those patients independently. In addition to that, they looked at, once the patient had been successfully treated and then followed for a number of years after that, what was the likelihood of having a microbiologic recurrence, acquiring a new infection over time? The blue line is the acquisition of new infections over time in patients with nodular bronchiectatic disease. The red line is new infections in those with fibrocavitary disease. And so it makes a big difference in terms of your risk of getting reinfected or acquiring new infections if you have this nodular bronchiectatic form of disease. So while they may respond better to treatment, they're also at greater risk of recurrences after treatment. The other condition that keeps coming up when we're talking about clinical trial design is whether we can lump cystic fibrosis and non-cystic fibrosis bronchiectasis patients in the same categories in those clinical trials. And there probably are some differences between those two groups with regard to NTM infections. The underlying pathophysiology of CF is that it's a monogenic disease, a single gene causing the disease, with fairly well-known disease pathogenesis or mechanisms of action. In non-CF bronchiectasis, we're lumping a lot of different diseases together. We've already talked about primary ciliary dyskinesia, alpha-1 antitrypsin, inflammatory bowel disease-associated bronchiectasis, that all may have differences of mechanisms of pathogenesis or deterioration that can affect or potentially affect their response in clinical trials. There's generally a big age difference between the two groups, with CF tending to be skewed more toward the younger age group, non-CF bronchiectasis toward the older age group. The types of outcome measures that you look at may differ in terms of their utility. FEV1 in CF studies may be a good reflector of response to medication. In non-CF bronchiectasis, maybe not so good. There may be more or different concomitant pathogens and more of a tendency toward exacerbation in CF than non-CF patients. And their CF patients' handling of certain drugs may be quite different. If you look at drugs like the aminoglycosides, there's what's called an altered volume of distribution, or how they eliminate that drug over time compared to non-CF bronchiectasis patients. And then there's been a fair amount of interest in our group and in others in looking at trying to better characterize patients that you don't have an associated reason for their underlying bronchiectasis, what's called idiopathic bronchiectasis. And many of these patients have been kind of lumped under the eponym of Lady Windermere syndrome, and there are reasons that label was put on it, but I think that sort of group of patients may have overlapping characteristics with a variety of known diseases. For example, genetic diseases affecting airway clearance. There's a big overlap with both cystic fibrosis and primary ciliary dyskinesia. Even in patients that don't have those pure diagnoses, there may be genetic and certain physiologic traits that overlap with a larger group of patients with idiopathic bronchiectasis associated with NTM. There have been physical characteristics that overlap a lot with conditions like Marfan syndrome or Ehlers-Danlos syndrome. Those are both genetic diseases that are characterized by things like being tall, being thin, having a high frequency of characteristics like curvature of the spine, indentation of the chest wall, and mitral valve prolapse. And in a study that we did a number of years ago, in general, those patients appear different from their age and gender-matched controls that were compared from one of the large nutritional databases. So by almost any measure of fat distribution, the patients that fell in this category were significantly thinner, but also taller and thinner at the same time. There's also a characteristic of the spinal cord, the sac that the spinal cord sits in, and on the far right-hand side, in patients with Marfan syndrome, it's very dilated and sort of have these kind of curvatures between the vertebral bodies, as opposed to normal on the far left-hand side. Patients with idiopathic bronchiectasis, many of them fall right in the middle, and this may be another characteristic that would separate those patients out clinically. We were very interested in looking at the genetic associations in those patients, and we took a cohort of fairly well-characterized patients with idiopathic bronchiectasis associated with NTM and sort of broke them down into familial groupings. Those patients where multiple family members were involved, and they were separated into family members that had NTM versus those that didn't, and what were called sporadic cases, where there didn't appear to be other family members that were involved. In those families, even in the unaffected, meaning not having NTM family members, a fair amount of them had conditions like underlying bronchiectasis or these connective tissue traits like curvature of the spine or indentation of the chest wall that made them look very much like the NTM-affected family members. And when we did a process called whole exome sequencing, where we looked at the coding messages in the DNA that result in protein formation, and we screened them for rare mutations or rare variants that look like they might have protein-altering effects, we saw more variants in categories like cystic fibrosis, cilia, and connective tissue genes in the patients that we studied compared to healthy controls from a large national database. There was overlapping bronchiectasis and connective tissue disease features in those unaffected family members, and their likelihood of having genes in those categories was equivalent between those that were NTM affected and those that weren't. When we looked at categories of genes that related to immune function, only the family members that had NTM involvement had an increased frequency of abnormalities in those genes. And it may be the situation where it might take minor changes in genetic risk to lead to development of bronchiectasis combined with minor changes in genes related to immune function that allow mycobacteria to sort of stick around long enough to cause disease, such that you're looking at a susceptible person's model of mycobacterial disease with increased frequency of these mild mutations or changes in relevant gene categories that increase the risk of bronchiectasis and NTM infection. So why does this matter? It might relate directly to treatment. If we can categorize patients by these underlying conditions, if it's cystic fibrosis, then the newer drugs, the CFTR modulators as they're called, that are making game changes in terms of prognosis and response to therapy in CF patients, some of those drugs may be applicable to patients who don't have the full-blown CF but might have genetic risk related to that and have an underlying treatment that might decrease their likelihood of getting reinfected or prevent infection in the first place. Similar to cilia-related variants, if we can learn what it is that makes cilia beat better or more efficiently, those treatments may apply to those patients. There are a variety of immune-related treatments now. If we can categorize patients that have milder immune defects, some of those may be applicable. And even these heritable connective tissue variants, many of those are associated with weak blood vessels like the aorta. And there are certain drugs that are used to treat that decrease those risks. Some of those drugs might have similar impact on the underlying lung disease as well. So with that, I'll stop, and thank you very much for your attention.